Good day everyone, today's video is about endotracheal intubation. We have here a COVID-19 positive patient for intubation at the ER with a blood pressure of 60 mm mercury, heart rate of 140, respiratory rate of 30, O2 saturation of 84%, and temperature of 40 degrees Celsius. These are the steps for the intubation of this patient. Instruments to be used: suction, airway, laryngoscope, endotracheal tube, plaster, and stethoscope. We also have the mnemonic maids. Inject 10 ml of PNSS to the endotracheal cuff to check for any perforations. For the procedure, first perform airway assessment. Look externally for large incisors and dentures, large tongue, short neck, and obesity. Evaluate using the 3:3:2 rule. Check for patient's Malampati classification, any obstructions, and neck mobility. Properly position the patient in a sniffing position, and you can use folded towels for this. For the basic airway, suction the secretions and vomitus which may obstruct the airway of the patient. Apply chin lift or jaw thrust to displace the tongue anteriorly. Apply bag mask ventilation and pre-oxygenate the patient with 100% oxygen. Give anesthetic drug, and since our patient is hypotensive, we can give intravenous succinylcholine. The appropriate dose would be according to the patient's age, lean body mass, and central blood volume. Once the patient has relaxed, do the Salix maneuver by applying 30 newtons or approximately 3 kilograms, then proceed to intubation. The laryngoscope is held in the left hand and inserted along the right side of the mouth, pushing the tongue to the left. Depth perception is difficult, and therefore structures should be identified as the blade advances past the tongue and epiglottis. The tip of the blade is inserted behind the vallecula. Traction is then applied along the long axis of the handle, and the jaw and tongue are pulled forward and up off the rest of the face. The blade should not be levered on the teeth as a fulcrum. This should provide a view of the vocal cords. Suction of pharyngeal debris is only indicated if there is massive aspiration, bleeding, or inability to identify the vocal cords. The endotracheal tube is inserted through the cords. The tube should be inserted just far enough to ensure that the cuff is past the cords. If a video laryngoscope is available in the hospital, then this is the best device, especially for our patient who is COVID-19 positive. Video laryngoscopy improves the ability to visualize the larynx, and intubation success approaches 97% to 98%. This moves the provider's point of view past the tongue, avoiding the need for a direct line of sight to the glottis. The tube must be 20 to 22 centimeters in. Inflate the cuff with 10 cc syringe. Remove the stylet. Check the position of the tube in the trachea by bagging the patient and listening for breath sounds over the lungs and stomach. There should be equal breath sounds on both lung fields and no gurgling sound in the abdomen. Check that the tube is not in the mainstem bronchus by inspection of the tube depth and auscultation. Tie tube securely in place using a tape. Take note of the ET level. Lastly, attach it to an oxygen source.